Professor H.D. Karunaratne, Vice Chancellor, University of Colombo, Professor Lakshman Ratnayaka, Chairman, Board of Management, Professor Senaka Rajapaksa, Director, Professor Chandani Anigatunga, Deputy Director of the Postgraduate Institute of Medicine, chairpersons and members of boards of study, trainers and trainees of the PGIM, ladies and gentlemen. It is indeed a rare privilege to have been awarded this prestigious oration, and I am grateful to the selection committee for bestowing upon me this high honor. I thank Professor Chandani Vanigatunga for her kind words of introduction. In this oration, I will be showcasing some original research highlighting the collateral adverse immune effects of modern radiotherapy. There are three main forms of cancer treatment: surgery, radiotherapy, and systemic agents. Contrary to popular belief, when it comes to actually curing cancer, it is mainly surgery and radiotherapy that play a major role. Systemic treatment receives a disproportionate amount of funding and focus, but only 6% of all cancers are actually cured by it. External beam radiotherapy is the commonest form of radiation, given as a beam of high energy X-rays generated by a linear accelerator, or as gamma rays produced by cobalt teletherapy units. But radiotherapy can also be delivered internally using a radioactive source known as brachytherapy, or engineered into a radioisotope that can be ingested or administered as an infusion. The focus of this oration will be on external beam radiotherapy and some aspects of brachytherapy. Tumor cells divide rapidly, relentlessly, and abnormally. Radiotherapy attempts to counter this by damaging DNA directly or indirectly through free radicals generated by its interaction with the molecular microenvironment. In the presence of sufficiently damaged DNA, cell division is interrupted and tumor cells suffer mitotic or apoptotic death. However, along with cancer cells, there are billions of normal cells in the body that are also dividing. Any treatment that targets DNA and cell division should therefore be able to preferentially spare normal cells in the body. This is achieved by dividing the dose of radiation into fractions and by focusing the radiotherapy beam very tightly to the tumor. We have indeed become cleverer in shaping the radiotherapy beam to conform to the contours of the tumor. From earlier two-dimensional rectangular fields, we have now moved to the era of precision radiotherapy, which is achieved by a technique known as intensity modulation, which allows the delivery of a high dose of radiation to the tumor while sparing identified organs at risk. As shown in this image, with the use of IMRT, it is possible to spare dose to the spinal cord and parotid glands in comparison to older techniques using rectangular fields. IMRT achieves precision by redistributing the dose of radiation to a larger volume. The downside of these strategies of dose redistribution is that they lead to irradiation of a larger volume of normal tissues to lower dose of radiation. This is known as the low dose bath. It has long been assumed that apart from the small risk of increased second malignancy, that this approach is safe and effective. But as shown subsequently, increasing the volume of tissue irradiated to low doses could lead to counterproductive immune effects that could impact on tumor control as well as increase toxicity. For tumor cells to proliferate, invade surrounding structures, and metastasize to distant organs, it needs to acquire a range of characteristics, which are commonly described as the hallmarks of cancer. In this oration, I would be focusing on one such property, avoiding immune destruction. Tumor cells, by definition, have to acquire genomic instability in order to acquire the characteristics needed to progress and proliferate. This leads to the expression of many abnormal proteins on the surface of the tumor, known as neoantigens. These neoantigens should, at least in theory, provoke an anti-tumor response from a competent immune system. However, tumor cells employ numerous strategies to evade and suppress the immune response against it. This could be by inhibiting effector immune cells such as cytotoxic T cells and natural killer cells, as well as by activating regulator T cells, which lead to an immunosuppressive tumor microenvironment. Tumor cells could also induce apoptosis of effector immune cells by expressing the programmed cell death ligand on its surface, turning the immune response on its head. The interaction between radiotherapy and the immune system is indeed complex. In many ways, radiotherapy can actually stimulate an anti-tumor immune response by exposing more tumor antigens to antigen-presenting cells and by engineering the release of cytokines that activate these cells. However, since effector immune cells such as cytotoxic lymphocytes are highly radiosensitive, radiation can lead to its depletion, both in the circulation as well as in the tumor microenvironment. The net effect of these competing processes will determine the outcome of the tumor. The high radiosensitivity of lymphocytes would suggest that these cells are prone to radiotherapy-induced apoptosis, even at exposure to very low doses which occurs in the regions of the low-dose bath. While modern radiotherapy technology has permitted greater precision in the delivery of radiotherapy by redistributing dose, the collateral damage to lymphocytes and effector immune cells have not been studied in great detail. In addition, irradiation of a larger volume of tissues to low doses could induce a pro-inflammatory state with release of cytokines by immune cells that lead to increased toxicity. In this oration, 4 original studies will be presented to highlight the adverse impact on the immune system of modern radiotherapy. All of this work was undertaken by me as a post-MD PGIM trainee. The first of these seeks to validate pre-treatment lymphocytopenia as a prognostic biomarker in bladder cancer. The second study looks at post-treatment lymphocytopenia in lung cancer, as well as the correlation between whole body radiotherapy dose and post-treatment lymphocytopenia. The third study looks at the effect of whole body radiotherapy dose on radiotherapy-induced fatigue in prostate cancer. And finally, we will be looking at brachytherapy as an alternative strategy of dose escalation without increasing whole body radiotherapy dose in prostate cancer. In the first study, which was published in Annals of Oncology, the objective was to investigate the prognostic significance of pre-treatment lymphocytopenia in muscle-invasive and advanced bladder cancer. All those involved in research related to prognostic biomarkers would know that one of the basic tenets is validation. Unless a candidate biomarker is validated in an independent cohort, it has very limited clinical application. In this study, we used a cohort of localized muscle-invasive bladder cancer patients as the test cohort, and a group of metastatic bladder cancer patients as the validation cohort. This was slightly suboptimal in that ideally the validation cohort should have the same inclusion criteria as the test cohort. But we did get away with it and ended up having our work published in one of the most prestigious journals in oncology, Annals of Oncology, which has an impact factor of 33, slightly below Lancet Oncology. This shows that it is not the complexity of biomarkers that matters, but rather having a simple biomarker is also acceptable as long as it is robustly tested and validated in an independent cohort. The test cohort comprised 74 patients with muscle-invasive bladder cancer. Half of them received neoadjuvant chemotherapy. They were treated to a dose of 52.5 gray in 20 fractions with weekly gemcitabine. Pre-treatment absolute lymphocyte counts were collected, and the outcome measure was disease-free survival. The validation cohort comprised 131 patients with advanced bladder cancer. They had systemic metastasis or unresectable nodal metastasis. They were treated with palliative chemotherapy, and overall survival was the endpoint. As shown in this slide, patients with lymphocytopenia had a poor outcome as opposed to patients with normal pre-treatment counts. As highlighted in this Kaplan-Meier plot, lymphocytopenia was validated in the advanced bladder cancer cohort, and on multivariate analysis, it was the sole prognostic factor. This was the first study to show that lymphocytopenia is an independent prognostic factor in both muscle-invasive bladder cancer as well as advanced bladder cancer. Lymphocytopenia could be a surrogate marker of impaired anti-tumor immunity. It is a simple investigation which is a part of routine workup of any cancer patient, and it would prove to be a very robust prognostic biomarker. In addition, it has the potential to act as a predictive biomarker for consolidative immunotherapy strategies targeting the PD-1 and PD-L1 pathways, which has already shown promise as adjuvant treatment following cystectomy in muscle-invasive bladder cancer. Having established the prognostic significance of pre-treatment peripheral blood lymphocytopenia, in the next study, we move on to test the prognostic significance of post-treatment lymphocytopenia. In addition, we would also be investigating the relationship between whole body radiotherapy dose and post-treatment drop in lymphocyte counts. Now, radiation oncologists measure dose delivered to organs and the whole body using various parameters. Since different volumes of tissues are irradiated to different doses, this variability of dose distribution is often captured in a histogram, known as the dose-volume histogram. In order to investigate the correlation between whole body radiotherapy dose and post-treatment decline in lymphocyte counts, we chose the whole body integral dose as the dosimetric parameter. To put it very simply, this captures the impact of high dose and low dose volumes in a single composite variable, and it is actually the area under the curve of a dose volume histogram. Data on clinicopathological variables, dosimetric parameters, and pre and post treatment counts were collected retrospectively in 217 lung cancer patients, 131 with non-small cell lung cancer and 86 with small cell lung cancer. Integral body dose was obtained by the product of mean dose and volume. A linear regression analysis was performed to predict the post-treatment absolute lymphocyte count, incorporating integral body dose, integral heart dose, integral planning target volume dose, as well as the use of concurrent chemoradiotherapy. Overall survival was analyzed using a Cox proportional hazards model. As shown in these box plots, there was a significant decline in post-treatment lymphocyte count. The median pre-treatment lymphocyte count was 1.7, which dropped to 0.5 after treatment. Multiple stepwise linear regression analysis confirmed pre-treatment absolute lymphocyte count, body integral dose, and use of concurrent chemotherapy as significant predictors of post-treatment lymphocyte count. Kaplan-Meier plot, patients with post-treatment lymphocyte counts less than 0.5 had a significantly worse outcome than those above this cutoff. In this study of lung cancer patients treated with curative intent radiotherapy, the prognostic significance of post-treatment lymphocytopenia was confirmed. In addition, this is the first study to demonstrate a correlation between integral body dose and post-treatment lymphocytopenia. Fractionation worsens the effect of post-treatment drop in absolute lymphocyte counts. The impact on irradiated volume on outcomes should be borne in mind when planning treatment with curative intent for localized lung cancer. Tighter definition of target volumes is of paramount importance. Since proton therapy results in a lower integral dose, locally advanced lung cancer patients might be suitable for treatment with this modality if it is available. The results of the Pacific trial, in which treatment with an anti-PD-L1 antibody following radical chemoradiotherapy resulted in a significant improvement of survival, suggests that anti-tumor immune response is important in consolidating the effects of radical radiotherapy. In this regard, post-treatment lymphocytopenia holds significant promise as a candidate biomarker for selection of patients for such strategies. Looking at these two studies, we can see that there are a number of biomarkers of tumor immune suppression. These range from very expensive and complex ones like gene expression signatures to immunohistochemistry for PD-L1 expression. There are simpler ones like the presence of tumor-infiltrating lymphocytes on histopathology, as well as peripheral blood lymphocyte count. Apart from being a very simple and cheap investigation, peripheral blood lymphocyte count has the advantage that it can capture the state of treatment after completion of radical treatment. Therefore, it is a more simpler and robust biomarker of anti-tumor immune incompetence. And it can be used to select patients for consolidative strategies after completion of radical treatment. In the next study, we investigate the impact of the whole body integral dose on fatigue in localized prostate cancer patients treated with curative radiotherapy. This was conducted as part of the Pan-European Required trial, which spanned over 30 centers across Europe, as evident from the number of authors in the publication. Radiotherapy-related fatigue is an underappreciated and troublesome toxicity. It is mediated by the effects of radiotherapy on normal connective tissues, which elicit a pro-inflammatory immune reaction. It is worth noting that most patients with localized prostate cancer, particularly those with low and intermediate risk disease, have an indolent course, and these patients are best served with a strategy of active surveillance. As such, toxicity of treatment assumes high significance, since most patients will die with prostate cancer rather than because of it. In this study, the hypothesis was that with increasing pelvic integral dose and a higher dose per fraction, fatigue would be worse. And to test this hypothesis, we used two cohorts, again in keeping with the tenets of biomarker validation. The test cohort was were patients in the required study, and the validation cohort was patients in the DU01 study in Milan. Fatigue is a very subjective symptom which makes its analysis exceedingly difficult and challenging. However, the European Organization for Research and Treatment of Cancer Quality of Life Questionnaire, EORTC-QLQ-C30, is a validated robust tool which enables an objective assessment of functional domains and fatigue. The worsening of scores pre-treatment to post-treatment were documented in the physical, role, and social functioning domains, as well as scores in the fatigue symptom scale. The outcome was defined as worsening in two domains, WS2 or 3, WS3. In the two cohorts of patients, different treatment schedules were used. Some patients were treated with 4 weeks of radiotherapy, others were treated with 6 to 7 weeks of radiotherapy. To account for the differences in fractionation and treatment schedules, we used weekly integral dose as the dosimetric parameter. This was derived by dividing the total integral dose by the treatment duration in weeks. The association between weekly integral dose and decline in functional outcomes, WS2 and WS3, were assessed using a linear regression model. In the required cohort, which was the test group, worsening in two domains was seen in 28% of patients and in 3 domains in 16% of patients. Weekly integral dose was 13.1 liters gray per week. Weekly integral dose, diabetes, the use of intensity modulated radiotherapy, and high dose per fraction was significantly associated with worsening outcomes. Interestingly, there was a small proportion of patients within the required cohort that were treated with older conventional techniques. And to our surprise, it was found that these patients had significantly less fatigue than those who were treated with the modern intensity modulated radiotherapy. The validation cohort had a lower prevalence of fatigue and a slightly higher weekly integral dose, but the model was validated with reduced discrimination. In this study, it was shown that 15 to 30% of patients with localized prostate cancer experienced significant worsening of fatigue following treatment with external beam radiotherapy. Weekly integral dose was validated as a predictor of worsening fatigue, and this is the first study to show a link between integral dose and an acute toxicity. Larger fraction sizes increase the risk of fatigue, and these findings are in conformity with the results of the Swedish hypo-RT-PC trial, which showed that which used a ultra-hypofractionated regime with high doses per fraction, and it also reported higher acute toxicity. We also found that patients treated with IMRT had worsening fatigue than those treated with conventional techniques, again suggesting that irradiating larger volumes to lower doses does have side effects in terms of fatigue. So what are the implications of these findings? Hypofractionation may worsen fatigue. Of course, it is more convenient to treat patients with a shorter duration of treatment, but we have to bear in mind that this might result in increased acute toxicity, especially fatigue. Since brachytherapy offers the opportunity of escalating dose to the tumor without increasing integral dose, it might be a more suitable strategy for dose escalation in localized prostate cancer. There are also implications for treating pelvic lymph nodes in prostate cancer, because including the pelvic lymph nodes in the treatment volume would undoubtedly increase integral dose, and this could lead to worsening fatigue. Therefore, careful selection of patients for pelvic nodal irradiation is necessary. In the final study, we investigate the role of brachytherapy as an alternative strategy of dose escalation to the tumor without increasing dose to normal tissues. Unlike external beam radiotherapy, in which radiation is delivered from outside the body, brachytherapy delivers radiotherapy from within, resulting in the ability to deliver very high doses to the tumor with a rapid dose fall-off and without increasing dose to surrounding normal structures. It does not result in an increase in integral dose, and it permits dose escalation using a highly conformal treatment modality. In this study, we looked at biochemical disease-free survival of patients with high and intermediate risk prostate cancer. They were treated with a high dose rate brachytherapy boost of 12.5 gray, followed by a hypofractionated course of external beam radiotherapy, 37.5 gray in 15 fractions. And we used the Astro definition as the outcome measure. Median follow-up was 65 months. As shown in this slide, most of the patients were high risk, with some having high intermediate risk disease. Biochemical disease-free survival was 80.5% in the whole cohort. It was 81.8% in patients with intermediate risk, and even in patients with high-risk disease, biochemical disease-free survival was 78%, which is a significantly higher figure for patients in this group. The results of toxicity were published previously, and it shows, as shown in this slide, there was very little long-term bowel and bladder toxicity. As shown in this Kaplan-Meier plot, there was no difference between the risk groups. Of course, patient groups were small, and even patients with high-risk disease had a significantly high biochemical disease-free survival. This study is unique in that it was the first to report outcomes in high-risk localized prostate cancer, where brachytherapy was delivered as a single dose in combination with a shorter fractionation regimen. It confirms that this approach achieves good biochemical control and with acceptable toxicity. The HDR brachytherapy boost also offers the opportunity to escalate dose to the dominant intraprostatic lesion of the tumor, and it permits dose escalation without increasing integral dose. Ladies and gentlemen, in summary, the 4 studies presented by me show that the price of precision achieved by a strategy of dose redistribution is paid by the unintended and underappreciated effects of the immune system, which leads to inferior outcomes as well as increased toxicity. I want to acknowledge all the co-authors, not just of the 4 studies presented, but all of the other studies, research projects that I was involved in. This is quite an exhaustive list. And I think one of the greatest benefits of engaging in clinical research is the opportunity to network and make new friendships. Permit me to make special mention of a few individuals. Professor Jayantha Balawardena, with whom I started my undergraduate, postgraduate, and research career in oncology. Professor Robert Grieve, who supervised my fellowship at the University Hospital of Coventry. Professor Ananya Chowdhury, my research supervisor at the Christie Hospital, deserves special mention. She was the supervising consultant for all of the studies presented in this oration. I also need to make special mention of Dr. J. Kumaran, the president of the Sri Lanka College of Oncologists, for constantly encouraging me in my research work. Last but not the least, I have to thank Dr. Sanjeeva Gunasekara, my friend and colleague, who has been a tower of strength to myself and all of us engaged in research in clinical oncology. Since this is the PGIM oration, I would like to mention that 13 years ago, I became a PGIM trainee, and this is now my 7th year as a consultant in the Ministry of Health. And in this short span, I've had the privilege of working in many oncology centers, as shown in this map. The dark blue districts are the regions I've worked with, and the light blue ones are the regions where I did outreach clinics. The most recent addition is Monaragala. And I want to pay tribute to all my esteemed colleagues working in these centers who travel across provincial boundaries, away from their homes and families. Your dedication to service has been a source of great inspiration to me, and I'm deeply grateful to each and every one of you for your warm friendship and support. Finally, I would like to thank my family, without whom none of this work would have been possible, my parents, my wife Minoli, and our 3 children for their constant love and support. Thank you, ladies and gentlemen, for your kind attention.